We have the privilege of working with Amy Graham with Travelwater Associates today to discuss ICD 11 and the big changes taking place here in the future. When you walk away from today's webinar, the intent is for you to recognize key updates to the new ICD 11 billing and coding requirements. We want to ensure that you all are able to apply the knowledge gained to improve support for revenue cycle training and education for your hospitals and state, and that you're able to summarize an overview of an IC11 guide that we've created for you all to support rural hospital implementation and provide it as a resource to your state SHIP hospital network. And with that being said, thank you for taking the time to complete our pre-polling. This gives us a really good gauge on our audience here, and I'll let Amal speak to what we have here.
Yep. So it looks like the majority, they have heard of ICD 11. A majority, what ICD 11 means to them is what type of certification will I need? And lastly, for a majority, on a scale 1 to 4 of my knowledge of ICD 11, it's limited at this time.
Thank you, Amal. I like the responses. We got a few. I'll cross that bridge when we get there. So, what a great segue to Amy. We will pass it to you. Thank you so much. Amy, take it away.
Hey, thank you so much for that introduction, and just welcome to the party where we start discussing ICD 11. One of the questions that we had for ICD 11, so Nick, I only showed, and Amala only showed the first poll coming up. Did the second poll come up on what does ICD 11 mean to you? Did all three of those come up?
Yes, all
Okay,
three
so
came up.
they all three did come up. Okay,
Yes.
So we got
so
majority originated certifications. We've got second to that is crossing the bridge when we get there, which is too funny. And then we've got some that have no direct impact and some that will retire before it happens. So the majority are in definitely
crossing the bridge
specific
when we get there.
certification.
All right. Hey, well, I appreciate that. And feel free to ask questions. If I don't have an answer today, it may be because an answer is not available, or it could be I need to do some additional research on that. And if you have some insight into it as we go through this, again, feel free to take yourself off of mute, raise your hand, put it in the chat. Very happy to just discuss that with you and cover those topics. So really what we're going to do for ICD 11 is just let's go through a history lesson, figure out what is ICD, what does that mean? Then we're going to talk about why we're going to make this change. Why are we even talking about it today? Why are we making that change? And then we'll get into what now. Okay, now that we know we're going to need to make the change, what do we need to do today? And then we'll finish it off with some questions and a call to action for you, and looking at the workbook that we have put together that you can share with your hospitals as to what the program is, what it looks like in the future, as well as some things that they can use today. So with that, a history lesson. So let's just start off at the beginning. What is ICD? It's actually the International Statistical Classification of Diseases and Related Health Problems. It's a standard that is overseen and endorsed by the World Health Organization. So I'll refer to them as the WHO throughout this presentation, but it is overseen by them and it is used worldwide. It's not just a United States thing or a North America type categorization. It is used throughout the world. Now, the current version that we are on, you've probably heard to it referred to as ICD 10. That was the 10th revision of this international classification of diseases. The WHO completed this code set in 1992, and 23 years later, the United States put it into implementation. So that's why when some people talk about, well, when will this go live and what do we need to do? And some people are like, I'll be retired by then. I remember when we went from ICD 9 to ICD 10 and just the impact, the changes and the training that had to go into place. And so what we are looking at now is just how to prepare our states and our hospitals and facilities and providers out there to get ready for this change with ICD 11. So ICD 11 is the 11th revision that the WHO has created of this categorization code. With that, it was officially put into effect on January 1st of 2022. So when they put it into effect, it was approved by the WHO, and there are countries who are actually using this information today. Now, for the United States, there is no implementation date set at this time. It was initially rumored that it would be rolled out by 2025 to 2027, but more recently, we've heard that it's 5 to 10 years out from now. So that could be 2030, 2039 or 2029 to 2030 to 2034, that type of time span for getting that implemented. Now, when thinking about ICD 10 or ICD 11, they talk about coders. You hear coders, that coding, that phrase being tossed about. What that is it is looking at diagnostic coding of the procedures that are being performed in medical organizations. It is a 7-digit code currently in this ICD 10 structure, where the first three digits are the category, the next three digits are the etiology, anatomic site, or severity, and then the last digit is the extension. And that extension is the type of fracture, the fracture care, complication of pregnancy, that type of information. When looking at an ICD 10 coder, you have different terminology that is used where phrases like and can be interpreted in the coding manuals as meaning either and or it means or. So when you look at a disease and it says and, it could be interpreted as either and or. You have includes notes. Includes notes appear under a 3-character code to further define that or give examples or the content of that category that is being used to capture the information in ICD 10. You have a phrase called with, and what that means, it's associated with or due to a specific illness. And then you have different characters like a plus sign or a check mark, which means that additional characters are required as part of that coding. When putting the coding together, you want what coders do is they first code the condition, the underlying etiology, and multiple body system manifestations that occur related to that underlying etiology. A lot of big phrases there. I feel like it's like these, um, multiple syllabic words that come through to say they code first where it's manifesting itself in the body. So they sequence the etiology first and then the manifestation second. They have a code in the title that says in diseases classified elsewhere are never included as part of it. And it's always you code the underlying condition first. You do have the plus sign where it says using additional codes, meaning that 2 codes are required to fully describe a single condition that affects multiple body systems. So again, you sequence first the etiology and then the manifestation. And this is where I say to all of the certified coders who are in the house, thank you. Thank you so much for the job that you do, because just looking at the words on this slide, that can be so very confusing and challenging. And yet, when you look at this information and capture it together, we see that they are looking at the medical documentation that a provider is putting into place and capturing all of this and making sure that it's being documented appropriately so that it can be included on the bills that are sent out for reimbursement. When looking at this, we're thinking about, okay, Amy, that's how you coded for ICD 10. But what's going to be needed in order for us to implement ICD 11? Well, one of the reasons why we think that it's not going to happen by 2027, that it may be in the next 5 to 10 years, is because the first thing, and this is what's going on right now, is that it's being evaluated for ICD-11 for the United States purposes. So there are a group of individuals, a team that is looking at evaluating this. It's being worked on by the National Committee on Vital and Health Statistics with the hearings that are there. And I believe that we actually have, Krista, I believe that you're part of that National Committee, aren't you? Do you participate with that?
That's correct. I am part of the ICD-11 work group, which is one of the, you can think of it as a subcommittee within the larger committee, the National Committee on Vital Health Statistics. So what we're doing is collecting all that information. Many of you saw the RFIs that I sent around, and then we provide that information to the committee, who is the one who will ultimately make the recommendations on implementing ICD-11 in the US.
And I thank you for doing that because it's just all of the different moving parts that are out there, and then what that impact is on providers and requesting that information and just who you're reaching out to. So thank you very much for doing that. So you've got subcommittees like this one that Krista is on, capturing this information, putting it before the National Committee on Vital and Health Statistics. Then it goes to the Notice of Proposed Rulemaking, the NPRM, from the Department of Health and Human Services, and it's published in the Federal Register. Very similar to how other federal items go through, it will be published in the Federal Register. During that time, it will be opened up for a comment period, and then from that, a final rule is published in the Federal Register. Once that final rule is published in the Federal Register, it will have an implementation date provided. But right now, it's still in that request for information process and pulling those pieces. Now, once that final rule is published, and there are a lot of updates that are going to be required, things like updating the systems and the software, your EHR, all of the EHR for your providers, how to get the claims billed out, billing it, going through to the clearinghouses, making sure that they can capture all of this new information in this ICD-11 format. It also will update claim forms, because while you look at the 7 digits that we had for ICD-10, you're going to see when we go to ICD-11, it can be up to 17 characters. So there definitely will be changes to claim forms that go out. You have payer systems that will need to be updated. Because we can get it together, we can capture it in the EHR, you can get it ready for billing, it goes through the clearinghouse, but if it can't be received by the payer, they are going to have to update their systems. There's systems like an 837 or an electronic remittance advice file, where they send the information back to say, yes, it was approved, and no, it was denied, it was rejected. That type of information, electronic exchange of information, going back and forth, making sure that it's being captured. And then another area where it will be impacting is in that reimbursement methodology. That you do have quality metrics right now that are playing into reimbursement for today. You have certain procedures that are reimbursed at a specific way that when we go to ICD-11 will need to be evaluated and included, and perhaps payer contracts and different types of areas updated for that new reimbursement item. And then training. The thing that we are always jumping forward to like, how do I need to train the coders? When thinking about the training, there will be training for your coders, for physicians. They will need to understand how this new process works. And then as well as training on other clinicians that are out there. And in addition to that, looking at other people who may come in contact with the ICD codes, whether that's ICD-10 or ICD-11, if it impacts their job, do they understand what it was before and where they're going to in the future? So in thinking about that timeline, one of the things that we've done is we actually prepared for you, a list of here are the things that you might want to take into consideration and look at. But when looking at this, we're not quite at the point of clicking it to say, yes, let's put a team together, because with some of the staffing challenges that people face right now, those same people may not be in place, and we'll need to make sure that we've got it on the horizon and looking forward to it. Now, a lot of people, if you went from ICD 9 to ICD 10, the question is, well, why are we doing this? Why are we making this change today? Well, when looking at it, what they are doing is the World Health Organization is making this change because ICD 10, when it went into effect for the world, was in 1992. That's before any of us had a cell phone with an iPhone that we were carrying around every day and looking at and using. So, when thinking about it, we're modernizing the disease classification for the digital world, looking at database structure and capturing all of that data and that information. What they are doing is they're creating a structure that is going to minimize the need for country specific modifications. Now, if you're like me and in the state of Tennessee, you might not think a lot about crossing borders and the care that we're providing crossing over countries. But if you are in some of our northern states or even our southern states along the borders with our neighboring countries of Mexico and Canada, you do need to make sure that those diagnosis codes, that if your patients are crossing those borders, minimizing the need for country specific code modifications, and then really expanding the scope of codes where it's giving better representation for cancer, for devices, medical devices that are out there, new medications, substances, severity, causes of illness, injuries. These are the items that will now be captured as part of this ICD 11 change. We're also going to establish flexibility. Now, I sort of laugh at this because it's like, wait, the digits are becoming so many more digits. How is this establishing flexibility? Well, the content model, what they're going to be doing is changing the architecture of how that ICD code is reflected. So the content model, it will have basic building blocks of the model of all foundations. And those foundations are right now, the WHO has three different foundation classifications out there. They have the ICD, which is the International Classifications of Diseases. They, they have the ICF Foundation, which is the International Classification of Functioning, Disability, and Health. And then you have the ICHI, which is the International Classification for Healthy Interventions. What this new ICD program, ICD 11, is doing is it's taking all of those three foundational items and putting them in a standardized grouping together. It will have linearization and tabular lists where every entity can figure only at one point in the classification, a monohierarchy. And it's created for a specific version. And then when comparing that foundations to the linearization, it contacts all of the World Health Organization family of international classification universe and puts them in a standard grouping categorization. And then the linearization is a subset only for reporting mortality and morbidity statistics. So some of those statistics that you see out there are captured as part of this World Health Organization, the WHO's classification of diseases and morbidity and mortality. Some other enhancements is that ICD 11 MMS is going to have tabular list. The overall structure is much the same as ICD 10. The index terms are going to be in language forms, so it's going to follow that language. There is an alternative name to it. You might hear it referred to as linearization. So the coders may hear ICD 11 or they'll hear it called as linearization. And then the structure of ICD 11 will have first the chapter, then the block letter, and then the number. And there are reference tools where it's broken into three parts, where you have the ICD, the intro to the ICD 11, using ICD 11, and then what's new in ICD 11. So the reference guides are going to capture that. It will explain what ICD is, explain how to use it, and then any new enhancements that come through will be included in the reference guides. Some other enhancements that are out there is that you will have STEM codes where categories are going to be assigned a STEM code. Sometimes they're used alone, but sometimes they're used in combination and dependent upon the documentation that the clinician is including as part of the medical record. An extension code an extension code extends the meaning of a STEM code to provide additional information, such as laterality. It's never used alone, and it always starts with an X, which is different from how they use the X character in ICD-10. Pre-coordination. It's relevant details about a clinical concept that is combined in a single STEM code. Post-coordination, where there's new research and relative details are linked together or combined with a forward slash or an ampersand. So that information is now being captured. And then sanctioning rules, where it prohibits combined codes. They are built in to prevent classification mistakes, putting those guardrails in place. Some noteworthy features: extension and clustering. Extensions are non-diagnosis codes that add to the flexibility of the classification. They can be used alone, but rather they're intended to be used as they are intended to be added to a STEM code. They are appended to describe the laterality, the acuity, the severity, and other dimensions of the injury and external causes, rather than having that ICD-10 adjunct code. Cluster coding is a new noteworthy feature within ICD-11. This is where they are combining 2 or more ICD-11 codes to describe a documented clinical concept. So we're going to a documented clinical concept. And it refers to a convention where with might be used. And in a future slide, I've got some information as to how that's going to look comparing ICD-10 to ICD-11. But what it's doing is where with might be used, and in ICD-11, either a forward slash or an ampersand is used and considered to be a character within that ICD-11 code. Now, I talked about it before, but now I'm going to show you the current ICD-11 code structure. You have the chapter, the block, and the number, where the chapter is 4 digits with a period and then another digit. Then you include the cluster coding of the ampersand character, another 4 digits, a forward slash character, another 4 digits, a period character, and then 2 digits. So remember, we had 7 digits before. Now we're going to up to 17 digits. This is why there's a lot of programming to be included with systems and the training to help people understand and that information. That's why focusing on that and looking at it. An example of ICD-10 versus ICD-11, this is where we start looking at essential hypertension. In ICD-10, if you ask a coder what that code is for essential hypertension, they would tell you I-10, essential primary hypertension. However, in ICD-11, the ICD code will be a BA00.Z, which is essential hypertension unspecified. Now, the big change when you see how it really impacts, okay, that went from 3 characters to 6 characters, or 3 digits to 6 digits. Let's look at the diabetes mellitus type 2 with a left diabetic cataract. In ICD-10, that ICD code is E11.6, type 2 diabetes mellitus with diabetic cataract. However, in ICD-11, that code will now be 9B1021 ampersand XK8G / 5A11, meaning diabetic cataract, left, type 2 diabetes mellitus. So in looking at that code, the 9B10.21, that's where it's specifying it was a diabetic cataract. The XK8G means that it was in the left eye. And then the 5A11 says it's type 2 diabetes mellitus. So when thinking about what this means, the impact, you can see before with ICD 11, or not ICD 11, with ICD 10, both of those ICD codes started with an alpha character, whereas in ICD 11, it's going to depend upon what chapter that medical item was found in, and then from that chapter, then expanding on with the additional clustering codes. So with this, the question comes up, what do we do now? When talking to people about it, they're like, what now? The first thing I say is take a deep breath. Don't panic. These changes aren't happening today. So there's still time to plan for the future. I was just talking to somebody yesterday. She's like, I'm really worried about ICD 11. And I'm like, okay, take a breath. It still has to go. They're still in the request for information stage. It's still going before the committees to be reviewed. It's not happening today. So there's time to plan for the future. So when thinking about the future, the one thing I stress to everybody is you need to stay focused on ICD 10. And what do I mean by staying focused on ICD 10? When thinking about, especially in our rural facilities, you have coding and you have billing. Coding, they talk about, coding is typically done. You're using ICD 10, where you're transforming this healthcare diagnosis and the procedures and the services into these alphanumeric codes. And the information is taken from the medical records documentation. You have billing, which is where you have a HCPCS or a CPT code, and that information is submitted on the claim to an insurance company to receive payment back. And that information is taken from the charge codes that are selected by the clinical staff. Now, with this, these are two common phrases that are used. A lot of times they're used interchangeably, especially in a rural facility, because the same person could do both of these functions, or it could be multiple people who are doing these functions. And you really want to make sure that they are staying on top of this process, that they are staying focused on coding to a high level of specificity, and then working with the billing staff to see what does the payer need to receive that information. Some of the best practices using this concurrent coding to improve medical necessity documentation. Looking at the charts, doing chart reviews today to say, are we capturing all of the information? Do we have it as specific as possible so that we have the appropriate medical necessity documented and that is being captured in that ICD 10 code? Having weekly nursing and HIM meetings to discuss that medical necessity, the charge capture opportunities, where you're holding department managers responsible for monitoring their revenue and usage, and the charge reconciliation. What does that look like? And then educating and training the staff on that appropriate charging and reconciliation process, working with them through that. Other best practices in looking at it is just overseeing any charge master issues in addition to conducting chart audits. How does that, establishing a team that looks at that, oversees all of it, seeing if there are any billing issues related to charges, managed care contracts, and any pricing updates that are there. That's the way to stay focused on it today, by focusing your attention on it. And you want to make sure the next thing to do, paying attention to today, staying focused on ICD 10, but then monitoring your data metrics. When looking at your coding data metrics, what does your productivity look like today? How do you have it documented? How many charts per hour that an inpatient coder can code, an outpatient coder, swing bed, and clinic? When talking to a lot of our rural facilities, I ask them, do you have the same person who codes the inpatient versus outpatient or swing beds? And they're like, oh, no, that's two different skill sets because they are looking at the information gets captured differently. And the services being provided in an inpatient bed or a swing bed are different than services provided, say, in an outpatient setting or in a clinic setting. So, tracking that coder productivity, what does that look like today? Establishing those metrics so that when we go forward into ICD 11, you've already set up that standard that we are going to track it this way. Quality tracking, the specificity of the disease. One of the big changes that occurred between ICD 9 and ICD 10 is that there was a greater specificity of the disease that's out there. And as you can see, when we go to ICD 11, it's only going to get more specific. So today, looking at the data metrics, are they reaching the highest specificity currently? Are there payer denials related to coding? I've heard discussions about certain payers that are out there that they've got AI tools that go out and say, it's an unspecified diagnosis. We can kick that back as not medically necessary because they don't have the highest specificity included. So, really monitoring those diagnosis codes, rejections that are being received from the clearinghouse. Can they even bill for it? Because they've got, do they can they bill for it? Do they have the appropriate amount of information captured on the claim that the payers are going to need to see? And then one of the challenges that we do see in our rural facilities right now is this days not final billed. You may hear it referred to as a DNFB, where there are claims where the patient has already received the service, the patient's been discharged, but the claim has not had a final bill related to it yet. Is that because the provider notes have not been captured? You have coding issues that out there where they're capturing that and looking at your billing. What does that look like for the organizations today? These are metrics that they can start monitoring and looking at today so that when they go to ICD 11, they have already established that environment of tracking these elements. Then also, another way that they can pay attention to today, ICD 11 is on the horizon, but today, looking at performing quarterly audits. Are there providers who may need additional training because they've done a quarterly audit and the results don't reflect uh, for one provider as they do for the rest of the providers within the organization? Is coder productivity? We talked about it a minute ago, but is it meeting that expectation of how many charts they should be coding per hour, per day, for the week? What does that look like? And how are they meeting these audits? And then finally, make improvements now. That you can really focus on ICD 10 by creating this cross functional team whose goal is to improve today's performance, looking at capturing that information that's out there. I know one of the initiatives and challenges that our facilities talk about are health equity, capturing all of the health equity outcomes and those codes. How are they making those improvements today? Because by focusing on it and creating that environment today will help for the future. But then, we need to have ICD 11 on the strategic plan. So you really want to plan for the future by preparing for tomorrow. One of the ways to do that is just looking at all of the areas that currently require the use or understanding of ICD 10. If you think about it, it's easier to go and ask somebody today, do you use ICD 10? Than to wait until ICD 11 goes live and have a department go, well, nobody told me about it. Well, you have the opportunity today to start asking those questions. This is a claim life cycle that we've put together that just shows all of the activities that are involved as part of just revenue cycle. And when looking at it, I could go through each one of these columns that's here and think, have every one of these in some form or fashion. Each one of these columns does get impacted by ICD 11, and here's how it could happen. And so, when looking at that, the pre claim, the pre visit activities, things that are done before the patient ever shows up, the patient arrives, what are you doing to capture it? But then thinking about the revenue cycle side of claim submission, inbound processing, accounts receivable management, and analytics, going through and identifying all of these different areas of where it could impact. And then also thinking about those support functions, month end closing. Now, I know the accountants in the house are probably going, ICD 11 isn't going to impact me. However, if you have a value based care program that's using diagnosis codes to determine that monthly check they issue to you, or maybe a quarterly settlement payment or a wrap payment, things like that, if it's related to diagnosis codes, it could be impacting it. So, when looking at this, looking within the organization to say, what are those areas within this that could be impacted due to ICD 11 and having them on the radar? And then developing for planning for the future by preparing for tomorrow, by developing a cradle to grave process flow map for the patient encounter that includes all the people, maybe not necessarily names, but the people who are involved in it, the policies, processes. I think about our rural health the clinics that they have all of these policy manuals that they have in place. What are they doing to capture that? What are processes within our physician practices, the provider offices? What do those look like? And have we mapped out what could be impacted related to it? And then looking at the systems that are being used, the software, reports, any processes in between, mapping out that entire cradle to grave process for that patient encounter. Now, on this slide is where we just show you, just a process flow, and you can see the different highlighted boxes in there in the different colors. You have the peach color, the yellow, green, and purple on there. And then down below, where we've identified here are gaps within the process today that we need to focus on. And then also where it has a corresponding number. So the yellow box numbered 1 in the process gap goes with the yellow box numbered 1 in the best practices. And going through with all of that to say, here's the gap in our process, here are best practices we need to follow. What do we need to do to get those best practices into play today? That we have the luxury right now of time to get this all together and start addressing these items today. Then also, you want to start engaging your key parties in the discussion. Start talking to the clinicians, letting them know ICD 11 is coming. We don't have a date for it yet, but it is coming, and you need to be aware that this is happening. Because when thinking about your clinicians, they may be part of a professional organization that will be sending out notifications or updates or webinars. And if you've informed them ahead of time that these activities are taking place, then when they get the notification, they'll be like, oh, perhaps I should send that to Amy. She might be interested in hearing this today. Definitely, I'm sure the coders are already talking about it because this is out there on the horizon. They do know that they should know that the World Health Organization has put it into place for certain countries that are out there, have already adopted it. And so having those conversations with the coders, helping them to understand that we need them to focus on ICD 10, helping to let the organization know where identified gaps are so they can be remediated today. Key parties in the discussion are IT, thinking about your systems and your service. The one thing that I shouldn't say I like to do, but it's sort of my party trick is I go and I talk to an IT person and I'm like, those wild card characters that we're never allowed to use in our passcode, like an ampersand and a forward slash. What do you say if I tell you that that is now going to be included as part of a code that will be used for capturing a medical diagnosis. And they're like, what? No, that's coding back here in the background within the programming. And I'm like, yes, but they are now using it. Having those discussions with your IT vendor, you're letting them know just early on, what does this look like? Be aware that this is happening. These codes that have typically been reserved are no longer reserved, or these characters, the ampersand and the forward slash, those are now going to be used as part of the medical coding and diagnosis coding with ICD 11. And because it's related to that cluster coding, it definitely is something that needs to be taken into consideration. And then discussing with your outside vendors and your services. I remember when we went from ICD 9 to ICD 10, and I get the phone call, Amy, you're using this AR vendor. Do they know? And I'd make the phone call and they'd be like, yes, we're on top of ICD 10. We know that it's coming. We're working on it. We will have training available for you. And they did. These outside vendors, they know, and they know their services will not work in the new environment if they are not ready for it. But you want to make sure that you're engaging all of these parties in the discussion, because from these parties in this discussion, they will be sending out updates that, these updates will come through. And Nick, you just sent me a note that says it's huge, going from the 17 plus characters with the data fill size. Exactly. It's going from 7 digits to 17 digits. And I remember back in the day that everybody would say, well, just add memory. Memory is cheap. It's like, yes, memory is cheap. But when you look at the certain cells right now, that if you look at a diagnosis code, it only has space for 7 characters. Yet all of those items will now need to be changed because of where it's going and what that looks like. So I just share with everybody to watch for updates, making sure that the different organizations, the professional organizations, as well as coding, the World Health Organization and the American Association of Professional Coders, different vendors will start talking about it. You'll start hearing this more and more. But then also to um, how Krista shared earlier, that there is a request for information now. They're asking the questions today as to what this impact will be. And is that getting to all of the appropriate parties to get their feedback? And then do those parties know that they should provide that feedback? So those are things that they can do to plan for the future by preparing for tomorrow, but also plan for the future by paying attention to today. So with that, we've made it to our question and answer section of this. Do you have any questions for us, or for me today? So what I will say, in addition to this, and I'm going to stop sharing my screen for just a minute, and I am going to pull up. We have put together a document that will be shared out there on the National Rural Health Center resource site. And I should be sharing it now. That has this document together where these information that I included today or discussed in it is part of this, where you have for preparing for it, what does that look like, how you can successfully implement ICD 11, just things to start thinking about today, as well as some additional resources. So, Nick, you and the team will be putting that out there. This guide will be shared out there, as well as there is an implementation strategy where we've put together a workbook of sorts of just who's going to need to be included in the discussion, what that is, and how those conversations go forward. We will be including that Excel document as well. So with that, that gets to the end. Thank you very much for paying attention to it. I will tell you, one of the things about SHIP with that SHIP grant is that your facilities have to have this training. And I know I talked to somebody this past week and they're like, no, I don't want to have that. Um, I don't want to talk about ICD 11. We just went to ICD 10. But having those conversations and just say, there are things you can do today to address it. So, Nick, you've got your hand raised. Did you have feel free to take yourself off of mute?
So I have a hospital that their documentation is on paper. So other than all the other issues with problems of doing that, what specifically are they going to be dealing with this paper? Because they're not going to do this until the end of this year. Convert over to electronic, that is.
Well, so Nick, what they can do is to make sure that in that documentation, in the paper that they have, it captures to the greatest level of specificity. It's everything that is taking place, that it's being captured on that paper, that they are capturing that information. Because I'll make the assumption, but it's what happened way back in the day before we all had electronic health records. Is that, and if you go watch old versions of ER, you'll see they had the paper chart. Where that paper chart goes, a coder is reading the information in there, creates that electronic health, that creates the ICD 10 code based upon the documentation that has been written on paper. And then from that ICD 10 information is including that on the bill to go out the door. It's just a matter of you can still do coding audits on that. They did them in the past before we all had electronic health records. It just didn't work as quickly. But what I would also say is for this organization that is going from paper to electronic in the fall, probably about mid next year, they need to have an organization come in and audit a sample of their charts to make sure that everything that is being documented is captured in that electronic health record with related to the codings. I would start building that in as part of just their implementation schedule. That they should already be using ICD 10.
Great question. And I really like how Amy, you and the Stratwater team framed this up around here. Let's tighten up our opportunities to have ICD 10 optimized from the entire revenue cycle process. Let's fix those things and then use that to evaluate how well we are positioned for ICD 11 when the time comes.
When thinking about that greater level of specificity, if you need to think about anything, it's that diabetes, where a patient had a cataract, it's a diabetic cataract, and it was in their left eye, and how it really changed it to, instead of just saying left eye issue with a cataract, it was more of it's a diabetic cataract, that greater specificity down to the ameliolitis and where that was. So that's what we say related to the specificity, not just saying they've got a cataract, okay, it's good, but when thinking about that, it's a cataract in the left eye, because insurance companies will come through and say they've already had it in their left eye. That's like, oh, the documentation didn't say it was the right eye the previous time, it's the left eye this time. That's where insurance companies do catch it, they send it back and they say, nope, we will not pay for that. They've already had it done. We need to capture that information today.
Really, really good. And you all will find that there's additional resources that help supplement the guide to include the template that Amy was referencing as far as what the hospitals can use right now as actionable to really start formulating their strategic planning around this. So lots of great resources that accompany the guide. Please use that as to help support your hospitals here as they're making this transition here and preparing for it in the future. And Teresa, to your question here in the chat. So after we go through our recording and posting on YouTube of this webinar presentation, both this recording, the ICD 11 implementation guide, and the templates, and all those resources will be located on the event landing page here. So please do come back, visit, send your hospitals to it, and help us to help support them. So
And
Nick,
I
I
would,
have another question.
certainly.
oh, go ahead.
So I have a hospital who's wondering because they've done ICD-11 training, and now they're wondering how can they stay in compliance with that each year since the same people are taking that training each year.
So
Go ahead.
Teresa, for the SHIP grant to remain in compliance with the ICD-11 readiness requirement, recall, and to Amy's point too, it's a lot right now of making sure that you are up to date with ICD-10. So again, billing and coding training, software, things they need that way, any updates to their EMR for integration, and then trainings, whether it's the WHO trainings, whether it's bringing in their vendors for ICD-10, whether it's bringing in another subject matter expert to do those types of things. It can be the same staff year after year, if that makes sense. It can be new and additional staff, as Amy outlined. Lots of people touch this process. So there are a number of ways to meet the requirement each year. And if you have a specific question for a specific hospital specific to your state, you can email myself or the center team and we'll work through that for you.
Okay, thank you.
Amy had something else you wanted to
I was
add
just
here?
going to say the one thing that I think, especially for coders right now, is just to help them understand that it's not happening today, but they must stay on top of ICD-10 to get to the as great a specificity as possible. That would just be my just tell them it's okay. You don't need to stress out about it today, as long as you are staying focused on the ICD-10.
And thank you all for taking the time to complete our post polling. We really appreciate the feedback. I know Amy does too. If we have any other last minute questions here, and with that being said, we'll see you hopefully again here soon. Y'all take care. Have a great rest of your afternoon. Thank you.